Video 2 of 3. Where did we leave off? Okay, briefly, brain injury conditions. What are we talking about here? 1. Dementia diseases such as Alzheimer's and vascular dementia. 2. Traumatic brain injuries such as from car accidents, gunshot wounds. 3. Repeated sports-related head injuries such as from boxing, football, and soccer. 4. Alcohol and drug abuse-related injuries, including anesthesia side effects. And 5. The catch-all, all other types. And related conditions are post-traumatic stress disorder and mild cognitive impairment. While these last two conditions are potential precursors to true injury, the top 5 mentioned relate to brain injuries that cause cognitive disruptions. And taking it one step further, it seems that all brain injuries similarly affect the memory abilities. They just do so to different extremes. Therefore, brain injuries in general do create the same day-to-day cognitive issues that are caused by dementia disease. Therefore, dementia disease, as the name implies, is not a normal part of the aging process. Not everyone that gets older gets it. And while a degree of normal forgetting undoubtedly occurs with aging, a contributing factor may also be that memories do change over time, although the original memory is able to be recalled. The short of it is that all brain injuries cause cognitive pathway breakdowns, which may prevent the recall of memories, as well as various psychiatric issues. Why? Because unlike the healthy brain, it seems an injured one is less able to switch to an alternate route. Therefore, the thought process that encounters the damaged pathway may simply end at that point. It would be like instead of switching roads to avoid clutter on your drive to work, you totaled your car and died. Additionally, when brain injuries do worsen, they tend to do so along generalized patterns, with some steering towards degenerative conditions called dementia disease. And when conditions do become degenerative, this seems to happen primarily due to the brain's somewhat ineffective self-healing abilities. This in turn seems to create prolonged inactivity in the affected areas, which leads to localized disengagement and then atrophication. Basically the same thing that happens to a car that sits parked for way too long. It begins to fall apart. This in a nutshell emphasizes the significance of the consultation technique. By rerouting and regrouping memories around the injured areas, this prevents thought processes from being lost. Additionally, as the consultation technique is able to switch between the different main lines within the injured brain, this makes it possible to determine whether cognitive issues are due to actual injury, due to mild cognitive impairment, or due to delirium adverse reactions. Why? Because the issues created by the 3 differing conditions are significantly different. And if the condition is dementia disease, it is able to be determined whether or not actual short-term memory issues are already happening, and potentially when and where the injury began. In short, the keys behind the consultation technique are: 1. All brain injuries cause similar effects, but only to different levels. 2. The injured brain seems to automatically follow the guidance of the consultation technique, just like a drowning man automatically reaches for a life raft. And 3. This guidance occurs in learning fashion. Therefore, over time, the brain is able to make the rerouting actions on its own, basically becoming rewired. Ineffectiveness with delirium adverse reactions. Of note, regarding delirium adverse reactions, the consultation technique has not demonstrated effectiveness in assisting with these situations. These are the conditions of temporary confusion, disorientation, usually associated with such things as infections, electrolyte imbalances, and inappropriate medications. That said, The difference between dementia and delirium adverse reactions seems similar to reasons why a computer may not work right. With dementia disease, there is actual injury, like worn out or damaged computer parts, which physically prevents both the brain and the computer from working normally. In contrast, delirium adverse reactions might be likened to a computer that is temporarily plugged into an inconsistent yet non-damaging power source. Returning to injury, briefly, aspects of dementia. Alzheimer's disease is considered the most prevalent form of the dementia disease and is therefore the most often diagnosed. However, interpreted research seems to indicate that all forms of dementia may be the result of the brain's various reactionary measures to micro blood vessel ruptures. In other words, the various dementias seem to result due to issues with strokes, or basically vascular dementia. Additionally, it seems that many strokes and many seizures may be indistinguishable from one another and may also actually cause the other to occur. That said, with all other factors seeming equal, why is it that with dementia disease, really good and really bad days seem to happen side by side? Well, it seems that worst day contributing factors are 1. The currently in use cognitive pathways are within a more damaged area, hence more cognitive derailments. 2. Minus actual derailments, microswellings within injured areas cause interferences between neighboring brain cells. And 3. The buildup of cognitive clutter will also contribute towards bad days. And leading into the concept of sundowner's syndrome is the idea that redirected cognitive signals happen normally within a healthy brain and also contribute towards cognitive clutter. Also normal within a healthy brain, on rare occasions, a misdirected cognitive signal may create what might be described as a harmless transient seizure, which only leads to a momentary loss of focus. But as the brain is healthy, the individual quickly returns back on track and without damage. In short, the healthy brain's cognitive pathways require normal maintenance to remove the buildup of clutter, and this usually happens during the sleeping hours, coinciding with overall rest and dream state activities. Okay, sundowner's syndrome seems to be a daily reoccurring state of heightened anxiety and commonly coincides with the onset of early stages of dementia disease. The syndrome usually seems to occur during the late afternoons or early evenings and may last into the night and early morning hours. And while some individuals may only seem to experience restless anxiety, others may demonstrate aggressive forms of anxious paranoia. Some may even feel the need to escape away from family. However, each individual experiences the syndrome differently, depending on how and where the brain is injured, as well as the individual's personality makeup. For example, one who was retired military demonstrated the syndrome by continually remaking his bed, hospital corners and all, well into the night and without apparent anxiousness or paranoia. In a nutshell, it seems that the onset of these dementia-related sundowner's issues are caused by abrupt changes with the cognitive maintenance schedule due to broken cognitive pathways and increased cognitive clutter. And in response to such intensive maintenance and healing needs, the brain does not wait for sleep, but instead is enticed or forced to begin maintenance far earlier in the day than normal. Unfortunately, the actual maintenance and healing needs far outpace the brain's abilities. Even so, the brain will continually attempt to repair and heal for as long as humanly possible, and thus the daily cycle begins, which means, as per normal healing protocols, rebuilding materials now arrive in conjunction with micro swellings in the attempt to realign and repair the damaged areas. Unfortunately, these misguided healing activities also hinder clutter removal, which in itself interferes with the neighboring cognitive workings. In short, this healing and maintenance activity is well able to erupt psychotic delusions, or simply chaos, of which may include irrationally aggressive fight or flight behavior. And unfortunately, it seems that this new Sundowner's associated activity will probably be the new norm for the person until the disease reaches a point where the body is either physically unable to attempt proper maintenance and repairs or is simply unable to respond erratically. And it is during these early stages of dementia when the consultation technique will provide the best results. For while it works towards increasing and expanding the injured cognitive abilities, this action automatically reduces the cyclic sundowner contributing factors. Therefore, the overall sundowning activity should diminish as the overall behavioral causing factors are reduced. Or taking a different view, it is during the early stages of dementia disease that a higher percentage of healthy cognitive abilities are still available for the consultation technique's workarounds. Additionally, the brain still retains a heightened ability to learn to avoid the disease areas. Therefore, by exploiting and expanding these very positive attributes early on by way of the consultation technique, the intense and magnified aspects associated with the sundowning time frame may well be avoided.